Right. So going to start the second part, which is on blueprinting for assessment. Uh, some questions are students' comments, especially about the essay type question. For example, here all questions on few systems only, no question from whatever system. Long questions for bouncer, I have not been taught these. So these are kind of common comments which we get from the students at the end of the examination, that one system was uh, so many questions coming from one system and there was no question from the other system, and some of the topics we were not taught. So quite common comments. Then another issue we have seen in number of papers, that some topics get repeated multiple times. For example, same topic being assessed in MCQ, in essays, in OSCE, short case, long case, etc. So uh, multiple times assessing the same, and whereas neglecting the others. So that's the issue we are going to address in today's session, and that's where the blueprinting really helps us. So the learning outcomes of this session, they explain the concept of blueprinting in medical education, apply blueprinting for students' assessment in their institutions, and apply blueprinting for identification of curricular content in their institution. We would be emphasizing more on for assessment in this session. Right? To understand the uh, blueprinting, we need to have some clear views about three important concepts. One is program learning outcomes, then is the constructive alignment, and the third one on appropriate methods of assessment. We will learn these concepts first before we go to the blueprinting. The learning outcomes, there are different levels of learning outcome. One is PEO, program educational objectives or outcomes. This actually means that what do we expect our students to be doing a few years after graduation? What percentage of graduates would be specializing? What type of specialties they would be choosing? So this is one based on the national requirement. The program educational objectives are set in such a way that the national requirements are met. So the what specialties are specially required in that situation. So the learning outcomes are program educational objectives of the should prepare the students for that. Next is the program learning outcomes. For example, MBBS is a program, so learning outcomes of the programs, and some people would say untrustable professional activities. Then is the CLO, which is the course learning outcome. For example, physiology is one course, anatomy is one course. So their learning objectives. And then is the topic learning objectives, for example, neonatal jaundice learning outcome. So these are the learning outcomes, and from PEO to PLO to CLO and to TLO, and we need to align them because the PEO and especially the PLOs would guide what would be the course learning outcomes and what would be the topic learning outcomes. And blueprinting can help align these learning outcomes because if we are not careful, we may have a program learning outcomes and our course learning outcomes and topic learning outcomes may not be in line with the program learning outcomes. And that's where the blueprinting can play a major role. Now, that's the first part is the learning outcomes. Second concept is of constructive alignment. Whether the teaching and learning activities and assessment tasks are in line with the learning outcomes. Basically, what happens is that first we identify the learning outcome, and that learning outcome would guide us what content we should teach, how that should be taught, and how that should be assessed. This is shown in another diagram here. Is the learning outcomes. They would tell us what content should be there, how they should be taught, what should be the teaching learning methods, and what should be the assessment methods. So everything is basically guided by the learning outcomes. Right now, here is an example of constructive alignment. For example, the learning outcome is that upon graduation, a student will be able to perform lumbar puncture under supervision and interpret the results. So this is, let's say, one program learning outcome that we expect a student after doing MBBS, he or she should be able to perform lumbar puncture, but under supervision, not independently, and should be able to interpret the results. So to achieve that learning outcome, we have to identify the content, the anatomy of spinal column, physiology of CSF, normal contents of CSF, and then taking consent from the patient to do the lumbar puncture. And the student should know what is aseptic technique, etc. So based on these learning outcomes, we identify the content. And then for each content, we have an appropriate teaching learning strategy. For example, physiology of CSF, which is functions, production, circulation, is best taught through interactive lecture and the best assessed through written examination. But if you talk about the aseptic technique, so obviously aseptic technique cannot be taught in a lecture. So there has to be a practical, either in clinical skill lab or in clinics. And of course, aseptic technique cannot be assessed in the written examination. So we have to assess in the OSCE or OSPE. Or you take the example of taking consent. Taking consent is best taught through a role play and best assessed through OSCE or OSPE. So this is the actual concept of the constructive alignment, that the learning outcome would help us to identify the content and would help us to identify the teaching learning strategy and would help to identify the appropriate assessment. Right. So the next concept which we want to look at is the appropriate method of assessment. Although I have mentioned a little bit in the the constructive alignment, but it goes further. For example, if we look at the Miller's pyramid, the first two levels knows how the best method of assessment is written examination, whereas at the shows level, it would be clinical simulation, OSCEs, for example. And at the does level is at the workplace-based assessment, where would be the portfolios, the log books, the 360-degree feedback, etc. And then on top of that is the addition of entrustable professional activities, means that how confident the assessor is that a student would be able to perform those functions under supervision or independently and confidently. So these three concepts are necessary to understand before we really understand what is blueprinting. Okay, now coming to the blueprinting is so blueprinting is defined as a complete plan that explains how to do or develop something. So basically, it is a drawing board which would draw the whole plan and the intricacies. So it's a complete plan that explains how to develop something. When it comes to the assessment, so it is a systematic approach to planning tests, an approach that documents what students should know and be able to demonstrate on each assessment. So basically, it is a planning to assess the students, and if we follow the constructive alignment, so it would be what would be the questions and how they would be assessed, and how the results would be finalized. So it is a detailed plan of assessment. To ensure that assessments are consistent with course learning outcomes and address truly important learning outcomes in a balanced manner, it is important that assessments must be developed according to a well thought out plan, which is blueprint. Obviously, we need a very well thought out plan, very clear and concise plan to assess the students, and that's what the blueprinting is all about. The congruence between three pillars of education, which is content, teaching, learning strategies, and assessment, can be facilitated by blueprinting, and it ensures the assessment tasks are aligned with the intended learning outcomes and teaching learning activities. So basically, as we mentioned earlier, that blueprinting is very, very useful to maintain the constructive alignment. In assessment, the blueprinting refers to a map or a table of specification for assessment to ensure that all aspects of the curriculum and educational domains are covered by assessment programs over a specified period of time. So based on last few slides which I have shown, we can clearly say it's the mapping of the assessment. And also we can call it a table of specification for assessment. And the purpose is that all aspects of the curriculum and educational domains are covered by the assessment program. It would be clear in next few slides. A test blueprint is a natural extension of the learning outcomes and course objectives. Of course, the assessment has to follow the learning outcomes and objectives, whereas it helps, blueprinting helps curriculum developers to match various competencies with the course content and the appropriate modality of assessment. So blueprinting, as we mentioned earlier, helping in curriculum in the constructive alignment would be helpful both in developing the curriculum as well as in assessment of the students. To ensure that curricular content is consistent with the PLO and CLOs. As I mentioned earlier, because now we mainly follow the outcome-based education. So it is the outcome which decides everything in the curriculum, whether it's a content, whether it's a teaching learning method, or whether it is assessment. So the blueprinting plays a major role in combining and in alignment of all these components. If we want to define the blueprinting in medical education, so we can define based on the test or based on the curricular content. So test blueprints describe the content to be covered by a test, along with other important features, which is emphasis given to each topic and assessment format. Whereas curricular content blueprints describe the content to be taught or learned to achieve PLOs. So these definitions may seem a bit complicated and boring in a way, but when we go and we see how we calculate that, that would really help to understand it. Okay, now going straight to the some views of blueprinting, because it would help us to understand. Now, this is the distribution of questions based on the input. Now, here we have modules. Here we have the sessions. Here are the disciplines. And this is the number of lectures or directed self-learning offered by the discipline. And then based on that, we can calculate the number of multiple choice question or single best answer questions or SAQ or SEQ or extended matching question or modified essay questions. Here in, let's say, in the CBS module, there are 37 lectures. There's 9 practicals, clinical skill lab sessions, interdisciplinary seminars, and problem-based learning. And let's say we take the example of anatomy, right? So anatomy has delivered the 5 sessions or 5 lectures. So this means that we have to allocate the appropriate portion to anatomy based on their input. So let's say the total number of sessions is 37, and out of that, 5 have been given by the anatomy. So anatomy would get the share of the questions based on the sessions given. Here, the major component is given by, for example, physiology. So they would have major portion. Now, based on this, if we have, this is end of module examination, and this is the professional examination. So when we want to distribute the questions among these disciplines, so out of, we know already know the number of questions which would be in the multiple choice questions. So based on their share, there would be 2 multiple choice questions from the anatomy and 7 from the physiology. So we can calculate the number of questions based on the sessions given by each discipline in each module. So this is for respiratory, and then this, CVS, and then there is a respiratory. And similarly, we can calculate the number of questions. So this is one component of blueprinting, where we distribute the questions based on the input, based on the inputs. Obviously, the discipline, because the contribution of for different disciplines would be different in different modules. For example, anatomy would be heavily contributing in musculoskeletal system, whereas physiology is heavily contributing in cardiovascular system. So the number of items or number of questions have to reflect whatever is being taught. So this is just one component. Now, if we go further and we want to see that what questions, which areas, that would be questions based on the topics. Each topic is covered. Now, in the previous one is on total number of sessions given, and now is based on the topic. So, because by this system, we can cover each topic. So we would discourage the selective reading by the students. And based on that, we can, let's say, anatomy, lecture 1, lecture 2, lecture 3, lecture 4. So their MCQs, their EMQs, their SAQ. So we can divide those questions based on the topics. This is the second component of table of specification or blueprinting. Another view, if you want to look at blueprinting, is sequence in clinical examination. So, for example, it's a clinical examination, and we want to decide what we want to assess and make sure that we do not repeat the same thing in different ways. So what we can do is we can make an exhaustive list of the topics, of the areas which are covered during the clinical years. And from that list, we will see that what areas we can assess in the long cases. We know normally what are the common long cases. So from that list, the list which we have made, we can strike out the topics which would be, or areas which would be covered in the long case. Next, we will see that what are the cases which will be covered in the short case, and again we would strike out those areas from the list. Similarly, then remaining OSCE, for example, the procedures, the communication skills, videos, audios would be in the OSCE, and we can strike out those areas from the list. Then comes the modified essay question, or SEQs, and then comes the MCQs. So if we divide in that way, we can cover almost the whole curriculum without duplication, without asking too many questions from one system. So this is based on the clinical sequencing on clinical examination. If you want to have a blueprint for OSCE, for example, and here are OSCE, here are the systems, the CVS, respiratory, GIT, reproductive, nervous system, musculoskeletal, are generic. And then these are the 4 areas which we would be assessing in the OSCE. So then we can divide that which system would be assessed in what station. For example, now in CBS, in history, we can have chest pain, and in explanation or counseling, we can have the drugs. Examination can be CBS examination or precordium examination. Procedures may be just test, for example, assessing whether students can take the blood pressure, or you can have ECG and others. Similarly, in the respiratory system, in GI, now in this way, we can, based on our emphasis, for example, if it's a year 3 or year 5, so history taking would be important. and the physical examination would be important. So in this way, we can make a blueprint, and the advantage would be that all the areas would be covered and that would not be duplicated. For example, in blood pressure in CVS and peak flow meter in respiratory system. Right now, having that idea that how we can apply blueprinting in different settings, let us look at really a comprehensive view of blueprinting, in a way, a scientific method of applying blueprinting. So steps, the first is define the blueprinting purpose and scope. Means that um, uh, the for which semester or which phase, whether it's for preclinical years or clinical years, or or it is for physiology or anatomy, what courses, and what assessment tools would be used, and how many questions. So before starting the blueprinting, we must know that, for example, in our MCQs, we want to use 60 questions. So we have to distribute these 60 questions accordingly, as I showed you in the previous table. So then we is the curricular content, the core based on the course learning outcomes, clinical presentations or topics. Then we need to identify the impact. We will go into the detail. The impact and frequency of each curriculum are identified based on the selected criteria, because we want to assess the important areas. We don't want to assess the minor prints. So that's why the impact and frequency are very, very important. I'll explain in detail in a short while. So to identify the area to be tested must be based on the impact and the frequency. Again, we can categorize the curricular content, what is must know and what is should know and what is nice to know. And based on that, we can also identify the areas that where should be the maximum emphasis and where should be the minimum emphasis. Once we have done that, then determine how many % questions should be constructed from must know, should know, and nice to know. And then they decide the number of items for each assessment. And once we have decided this, now we have, for example, we say that we need to have 10 MCQs from physiology, and these are the areas the MCQs should be. Then we send this detail to the physiology department and ask them to prepare the questions accordingly. I'll show you the exact calculation, which would make it really, really clear. This is an other way. It's from article published in Medical Teacher, and that blueprinting stage and the key activities. For example, identifying major knowledge and skills domains. Sorry. And then delineate the assessment objectives, decide on the assessment format, and specify the categories with. So this is another way of looking at the content and the type of questions we want to use in the examination. Now let's go in these steps one by one, and that would explain. So first is define the purpose and scope of blueprinting. And then we have to answer 5 questions here. First, which level, semester, or phase of the study the blueprinting is being prepared for? Are we doing for year 1 or year 2, or we are doing for clinical years? That's the first one. Second, which courses? Okay, now whether if it depends whether we have integrated curriculum or we horizontal integration or vertical integration. So means that whether we are exam is only for physiology or multiple disciplines. Third, what assessment tools we are going to use. The multiple choice questions are asking. And it can be both. What would be the total number of questions along with distribution of question according to assessment methods? And what level of questions are required at the particular level of assessment? We may use the Bloom's taxonomy for this. And based on the learning outcomes of the course at that particular level, is it promotional level or exit level? Exit level means it's a high stake examination, so we have to be more searching about it. So first step, define the purpose and scope. We have to answer these 5 questions. The second would be the listing of the content. The curricular content can be listed in many ways according to curricular setting. We can present in the form of topics, lectures and practical sessions, clinical conditions, symptoms, signs or themes. So we can, the content can be grouped under different headings. Now look at this table, and we have to be a bit, concentrate on this. Now here, this is from University of Calgary, and if you see the content is in the presentation form: hypernatremia, hyponatremia, hyperkalemia, etc., etc. And then is the impact, and then is the frequency. The definition I'll tell you in a minute. Impact means that how important that topic is for a medical graduate, and frequency means that how frequent those situations arise. For example, in countries, developing countries like say Pakistan, if we talk about pediatrics, gastroenteritis is a common problem, and then there would be electrolyte imbalance, whether hyponatremia, hypernatremia, etc. So in that situation, the impact is very high, whether 2 or 3, and it is very frequent. So once we have identified the impact and the frequency, which is based on our experience and discussion among the staff, then we multiply the impact with the frequency, and that gives the weightage. Weightage means that once we have calculated this impact time frequencies of all the topics, then we have a total here. In this example, it is 80. Now, to calculate the weightage, we have to based on the number of questions and impact factor, we need to calculate the weightage, which I'll show you here just now. Weight is impact times frequency over 80, which is 80 is this number. 80 is this number. So here we have calculate the weight, right? And based on that, the further would be the number of items. How do we calculate? The next table would explain it in a better way. Before that, we need to understand the what is impact and what is frequency. Impact, if a situation is non-urgent and of little preventive potential, the weight is 1. If it is serious but not immediate life-threatening, is 2. If it is life-threatening, emergency or high potential for prevention, is 3. Now this we can define in our own way. So we may have a different definition. Then is the frequency, that if something is very common, then impact the weightage is 3. if relatively common 2, and if rarely seen 1. So in this way, for every topic, we would have impact and we would have frequency. Now, again, this is another way of looking at it. Now, if we are talking about, let's say, phase 1, which is the preclinical. So now in preclinical or phase 1, now our criteria is for phase 2, means that what would be the importance of that topic for these students in phase 2. And if it is in phase 2, means the clinical, then we have to see that what would be the importance of that topic as a house officer, right? So here for example, there is something which we are teaching in preclinical years, but it is less important when it goes to the clinical. So that would be the impact 1 of if it is important 2, and if it's very important 3. Similarly, frequency. And then from the graduation to the house officer. So in this way, we assess the impact and the frequency. Impact based on the importance of that topic in the clinical phase, and frequency, that how frequent we see that. Now, you see, we are looking at the table again, the same table again. So we have the presentations here. We have the impact, like I said, hyponatremia is more common than are more important than hypernatremia and their frequency, and then we multiply impact with the frequency, and then total them up, and this is 80, which is impact times frequency. When we want to calculate the weight, then is impact times frequency over 80. And this would be the weight for this topic. And then we know what is the maximum number of questions we are going to use. So we would multiply the maximum number of questions with that weight to calculate the number of items. So when there is let's say hypernatremia, we have the impact 2, frequency 1, impact times frequency is 2. 2 divided by 80 is 0.025, and 0.025 multiplied by 60 would come to 150. So we can now round up that, okay, there should be 1.5 items, so we can convert it to either 1 or in 2. So in this way, it gives us an idea that how many questions on that topic should be used. Let's say if we are talking of hyponatremia, the impact is 3, the frequency is 2, impact times frequency is 6. So 6 over 80 gives us 0.75. And when we 0.075, we multiply by 60, it gives us 4.5. So means that we can have rounded up that much number of items. So this is how we can use the scientific method to calculate the number of items on each topic. Right? Now, here is another example. Let's say it's a distribution of items in CBS examination. Talking about the clinical. So we see in CBS the topics VSD, ASD, PDA, tetralogy of Fallot, rheumatic heart disease, myocarditis, infective endocarditis, congestive cardiac failure. So these are the topics I'm talking about pediatric posting, and in that posting, the CBS component. So these are the topics. And then for each topic, we have the impact. So the pediatricians would sit down and say that how important that topic is for uh, for training of the students, and then how frequently uh, we see that condition. So then we multiply impact with frequency, and that becomes 6. And so because total number is 24, so 6 over 24, it gives us a weightage of 0.25. Now then because the total number of questions we have 60, so 60 divided by multiplied by 2.5 would give us a number of 15. So this means that 15 questions should be related to VSD, and then we divide these questions. That how, for example, in this situation, we say that the 10 questions would go into the clinical, which can be in the long case, in history taking, physical examination, investigation, etc. And 5 questions come into the written examination, which would be the complications of the disease, our treatment, our pathophysiology, and related to basic sciences. So in this way, we cover all the diseases, we calculate their number of items, and then we divide them and the questions so that we can cover that topic very, very thoroughly uh, uh, and without duplicating. Right? So next step is categorize the items in terms of priority. So that's what we were saying: must know, should know, and nice to know. Must know is the minimum requirement that student cannot graduate unless they know the must know component. Should know would be a good student, and nice to know would be the students are the distinction students. So if a student is able to cover nice to know component, he or she should be considered for distinction. So weightage can be correlated to these categories. For example, weightage of 6 to 9 would be like must know. A life-threatening condition must be included in this category, irrespective of their weightage. And the weightage of 3 to 4 should know, and weightage of 1 to 2 would be nice to know. So in this way, we can correlate the weightage with the must know, nice to know, should know, and nice to know categories. And then based on that, decide the percentage of questions in each category. Here, the classification of curricular content, let's say we say 60% questions should come from must know, 30% from should know, and 10% from nice to know. And then these 60% questions can further be divided into multiple choice questions or structured essay questions, OSCE. This is in semester 1. And the same thing if we want to do in professional examination, we can use this. Right, so that's how we calculate that. And then once it has been done, the whole department should agree to that, and reliability is improved by increasing sample size and breadth. So more people involved in this, especially when we discuss about the impact and frequency, if all the people are involved in the department, that would make it more reliable. So HODs, head of the department, and if teacher relevant, even the senior students can be consulted on this, deciding about the impact and the frequency. So if we involve all the staff members, then it is more likely to be accepted and practiced. And then decide on number of items, total number of questions. The reliability of an evaluation is affected by both the number and discrimination of the items. let's say a rough guide, if average discrimination index is 0.3, then approximately 50 to 60 items are needed to achieve a reliability of 0.8. So it depends that what is our target. To have a discrimination of 0.3 is very, very good. And this means to have that discrimination and to have a good reliability, we must have 50 to 60 questions. But if, for example, the discrimination is less, then we need to increase the number of questions. So based on our previous experience and examinations, when we have the discrimination and difficulty index available, we can have an idea what should be the total number of questions and how they should be distributed. Now allocate items to content areas. So this can be done by multiplying the total number of items on the evaluation by the relative weightage, which we have done earlier as well. For example, 60 item evaluation on the renal course should have 7 items, because if you remember the relative weightage was in that table 0.1125, and we multiply by 60. So that gives us 6.75, which can be rounded to about 7 questions. But because the weightage for hyperkalemia is relatively less, the weightage for polyuria is relatively less, so there would be less number of questions. Then next step is decide on the task for each content area, and based on the number of items, choose the task or method of assessment, such as the history taking, the physical examination, investigations, diagnosis, management, and prevention and complications, pathogenesis, etc., and basic sciences. And so once we have this blueprint designed, then all the assessments, whether it is a continuous assessment, whether it is a formative assessment, or whether it is summative assessment, all these assessments should follow that blueprint. So means that some of those items would be examined, become part of continuous assessment, others would become part of formative assessment, and the remaining may be in the summative assessment. Right, before we go further, is there any question or comment about the calculation, the way we deal with it?
No, sir.
Right.
ये जो सारा हम ब्लू प्रिंटिंग वगैरह सारा कर रहे हैं वो हमारे लिए है, यानी फैकल्टी के लिए होता है, या हम ये स्टूडेंट्स के साथ भी शेयर करते हैं?
थोड़ी देर में इसका जवाब दूंगा. We have a slide on that. So आप ये फॉलो कर रहे हैं?
जी जी सर, इसको फॉलो कर रहे हैं.
वेरी गुड.
सर एक क्वेश्चन मैं कर सकता हूँ सर?
जी जी जी
सर काइंडली ये कंटिन्यूअस असेसमेंट और फॉर्मेटिव असेसमेंट में डिफरेंस थोड़ा दोबारा काइंडली सर एक्सप्लेन कर देंगे?
राइट जी. फॉर्मेटिव असेसमेंट सर वो होती है जिसमें हम स्टूडेंट को फीडबैक देते हैं, और इस असेसमेंट का उसके फाइनल रिजल्ट पे कोई असर नहीं होता. राइट आपने लेट्स से आप अगर क्लिनिशियंस हैं और आप स्टूडेंट ने केस प्रेजेंट किया है और आप उसको फीडबैक देते हैं कि आपके केस प्रेजेंटेशन में ये चीजें अच्छी थी, ये चीजें हैं जिन पे आपको मेहनत करनी चाहिए, ये उसको एक आपने फीडबैक दे दी, लेकिन आपने इसके कोई मार्क्स उसको नहीं दिए कि जो उसके फाइनल एग्जाम में जाएंगे. ठीक है जी. फॉर्मेटिव असेसमेंट क्लियर हो गई आपको?
जी सर.
या कंटिन्यूअस असेसमेंट ये है कि ये जो लॉग बुक है और जो हम प्रोसीजर्स और ये, तो कंटिन्यूअस असेसमेंट जो है वो कंट्रीब्यूट करती है फाइनल मार्क्स में. यूजली हम लॉग बुक यूज करते हैं जिसमें हम मार्क्स देते हैं कि उन्होंने कितने प्रोसीजर किए, कितने केस प्रेजेंट किए और कितनी एक्टिविटीज में हिस्सा लिया। सो कंटिन्यूअस असेसमेंट वो है असेसमेंट जो रेगुलर बेसिस पे कंटिन्यूअसली साथ साथ चलती रहती है और ये कंट्रीब्यूट करती है फाइनल मार्क्स को या समेटिव असेसमेंट को।
ओके सर, थैंक यू सर। तो मुझे थोड़ा सा कंफ्यूजन हो रहा था कि क्या हम फॉर्मेटिव असेसमेंट में कंटिन्यूस असेसमेंट डाल सकते हैं?
ये आप पे है, आप बिल्कुल डाल सकते हैं अगर आप चाहें तो। आप जो है फॉर्मेटिव असेसमेंट को आप फॉर्मेटिव और समेटिव दोनों तरीकों से यूज कर सकते हैं। मतलब आप स्टूडेंट को फीडबैक भी दे रहे हैं और उसकी असेसमेंट भी कर रहे हैं, लेकिन ये कोई ज्यादा मतलब अच्छा मेथड नहीं होगा। फॉर्मेटिव असेसमेंट को फॉर्मेटिव ही रहना चाहिए, क्योंकि अगर स्टूडेंट को ये पता हो कि ये समेटिव में भी कंट्रीब्यूट कर रही है तो वो फिर खुल के आपसे क्वेश्चन नहीं करेंगे और डिस्कशन नहीं करेंगे। लेकिन स्टूडेंट को पता हो अगर कि ये असेसमेंट जो है ये मेरे फाइनल प्रोफेशनल को इन्फ्लुएंस नहीं कर रही है बल्कि मेरी इम्प्रूवमेंट के लिए है, तो स्टूडेंट को ज्यादा जो है वो इंसेंटिव मिलेगा कि वो आपसे मजीद डिस्कस करे और इम्प्रूव करने की कोशिश करे।
ओके सर, थैंक यू सर, थैंक यू।
Right. Now, the benefits of assessment blueprint questions being asked are aligned to learning outcomes. Assessment covers the whole curricular content adequately. Assessment is valid and fair to the students. And assessment focuses on thinking skills and on depth knowledge. The content, competencies, and tools for assessment are rational and balanced, and the methods of assessment are appropriate for the areas being assessed. And there is, the students say that this question is out of syllabus, but that doesn't happen. There is no question out of the typical sentence of out of syllabus. The blueprinting reduces two major threats to validity. That's another important thing to understand about the blueprinting. एक है कंस्ट्रक्ट अंडर रिप्रेजेंटेशन और एक है कंस्ट्रक्ट इररिलेवेंस वेरिएशन। जो CU या कंस्ट्रक्ट अंडर रिप्रेजेंटेशन ये है कि कोई कंटेंट जो है वो प्रॉपरली रिप्रेजेंट नहीं किया गया। जिस तरह हम शुरू में कह रहे थे कि जी बहुत से क्वेश्चन एक सिस्टम से आ गए और दूसरे सिस्टम से कोई क्वेश्चन नहीं पूछा गया, तो वो वुड बी कंस्ट्रक्ट अंडर रिप्रेजेंटेशन। और कंस्ट्रक्ट जो है इररिलेवेंट वेरिएंस मींस दैट जो एरर्स हैं, द फ्लॉड आइटम्स, जो बात स्टूडेंट इसलिए परफॉर्म नहीं कर सके कि क्वेश्चंस जो हैं वो अप्रोप्रिएट नहीं थे, उसका स्टूडेंट्स के नॉलेज से कोई ताल्लुक नहीं था। जिस तरह हम सुबह डिस्कस कर रहे थे कि अगर हमने स्टूडेंट को बताया नहीं कि हम क्या एक्सपेक्ट कर रहे हैं, हम 5 रीजंस पूछ रहे हैं या 2 रीजंस पूछ रहे हैं और किसी ने 2 लिख दी और किसी ने 5 लिख दी और हमने उनको डिफरेंट मार्क्स दे दिए जबकि हमने वो चीज बताई हुई नहीं है पहले, तो दैट वुड बी, उससे स्टूडेंट का रिजल्ट जो है वो अफेक्टिव होगा, उस पे उसका इफेक्ट पड़ेगा। हालांकि उसमें जरूरी नहीं कि स्टूडेंट जो है नॉलेज वाइज वीक हो। तो ये है जो है कंस्ट्रक्ट इररिलेवेंस वेरिएंस के ऐसे कंफाउंडिंग फैक्टर्स हैं जिनका स्टूडेंट के स्किल से नॉलेज से कोई ताल्लुक नहीं है, लेकिन वो स्टूडेंट के रिजल्ट को इन्फ्लुएंस करते हैं। Now, the question you just asked, can blueprinting be distributed to the students? It was reported that distributing assessment blueprint to students does not improve student performance, but significantly increases the perception of fairness of the evaluation process. ये एक स्टेटमेंट है जिसका ये रेफरेंस नीचे है। दूसरा है कि if we disclose the blueprint to student, will it lead to strategic learning? Means अगर students को blueprinting का पता है तो क्या वो खाली वही areas पढ़ेंगे जो blueprint में है? Theoretically, yes, but based on the study, this was unsupported. So our suggestion is that if the total number of curricular content is more than the number of questions, we suggest not disclosing it to the students, since disclosure of these blueprints may lead to strategic learning. Means के अगर आपके जो क्वेश्चंस हैं वो पूरे करिकुलम को कवर नहीं कर रहे, आपके क्वेश्चंस पूरे करिकुलम को कवर नहीं कर रहे, तो फिर डिस्ट्रीब्यूट नहीं करना चाहिए, क्योंकि उस सूरत में स्टूडेंट्स जो हैं वो स्ट्रेटेजिक लर्निंग पे आ जाएंगे. ऑन द अदर हैंड, अगर आपके क्वेश्चंस जो हैं वो कंटेंट से ज्यादा हैं, फर्ज करें आप ये कहते हैं कि हर लेक्चर से हम 2 क्वेश्चन देंगे, तो उस सूरत में आप जो है बेशक स्टूडेंट में डिस्ट्रीब्यूट कर दें, क्योंकि उसमें तो स्टूडेंट्स हैं, उनको कवर करना ही करना है. तो ये आप देख लें कि इस तरह से अगर आप का पूरा कंटेंट जो है रिप्रेजेंट नहीं हो रहा एग्जाम में, तो उस सूरत में आप ये स्टूडेंट्स में डिस्ट्रीब्यूट नहीं करें. राइट? With that, I thank you for your attention, and if any questions, I will be happy to answer.
सर इसमें जो मैंने पिक किया, मुझे लगा आपने ये कहा कि जो यानी मस्ट नो वाले क्वेश्चंस हैं वो स्टूडेंट्स को पता होने चाहिए.
नहीं,
इनके वो प्रायोरिटी बेसिस पे अगर हम करें तो जो मस्ट नो, और आपने बताया ना 3 कैटेगरीज.
नहीं मैडम, मैं कह रहा हूँ कि अगर क्वेश्चन ये था कि आप जो ब्लूप्रिंट बनाते हैं, फर्ज करें आप कहते हैं जी के एनाटॉमी में हम 15 क्वेश्चन देंगे और वो इस एरिया से आएंगे
जी,
क्या ये इंफॉर्मेशन
ऑब्जेक्टिव्स तो स्टूडेंट्स के पास होते हैं हमारे.
ऑब्वियसली जब आप आउटकम बेस्ड एजुकेशन को फॉलो कर रहे हैं और उसके लर्निंग ऑब्जेक्टिव्स हैं, तो स्टूडेंट्स को पहले से पता है कि क्वेश्चन इन एरियाज में से आने हैं, इनसे बाहर नहीं आएंगे.
Yes.
हाँ, तो आई थिंक दैट इज फेयर एनफ एंड गुड एनफ.
जी सर. तो ये जो सर ब्लू प्रिंटिंग हम करेंगे वो अपने लिए, हमारे लिए,
जी, उसके लिए.
ठीक है, थैंक यू.
जी
सर ये भी जब एग्जाम हुआ और स्टूडेंट्स ने कहा कि सपोज के 18 चैप्टर्स हैं, लेकिन उन्हें सिर्फ 3 चैप्टर्स में से असेस किया गया
जी.
और जो है फिर जैसे मैंने आपको पहले भी बताया कि स्टूडेंट्स को कहा गया कि एफएससी वाली बात छोड़ें कि आप 3 साइड फैक्ट्स लिखेंगे तो आपको 3 नंबर मिल जाएंगे.
जी.
तो और किसी स्टूडेंट को ऐसा ही हुआ, किसी को मतलब 3 लिखने पे 1 नंबर मिल गया, किसी को 2 मिल गए, किसी को 3 मिल गए. और दूसरा ये मैं अपनी तरफ से फ्लॉज बता रही हूँ जो हमारे क्वेश्चन मेकिंग में आते हैं, और हमने उनको अच्छी तरह बताया नहीं कि हम चाह क्या रहे हैं. तो हर स्टूडेंट ने उसकी डिस्क्रिप्शन थी, उसने जो उसको समझ आया उसने वो लिख दिया. तो सर टाइम लिमिट हमने कर दिया कि जी ये एक आपने क्वेश्चन 5 मार्क्स का है, लेकिन सर हम उसके 4-5 लंबे लंबे पार्ट्स बना दिए. तो इस सब में स्टूडेंट कहाँ स्टैंड करता है, वो क्या कर सकता है? उसके ग्रीवेंसेस हैं कि भाई हमें अच्छी तरह बताया नहीं गया, हमें टाइम कम दिया गया, इस तरह में वो क्या कर सकता है स्टूडेंट?
तो मैडम मुझे यूं लगता है कि आप जो है आउटकम बेस्ड एजुकेशन को फॉलो कर रहे हैं, लेकिन असेसमेंट आप पुराने तरीके से कर रहे हैं.
सर लगता है
तो ये दैट इज बेस्ट रेसिपी टू फेल अ सिस्टम. अगर असेसमेंट और जो टीचिंग है साथ साथ नहीं चल रहे, स्टूडेंट तो तैयार करेंगे चीजें असेसमेंट के लिहाज से. अगर आप असेसमेंट में सुपरफिशियल नॉलेज पूछ रहे हैं, मेमोराइजेशन पूछ रहे हैं, तो स्टूडेंट उसको रटा मारेंगे. लेकिन अगर आपकी असेसमेंट ये है कि आप उनकी अंडरस्टैंडिंग चेक करते हैं, तो फिर वो उसको गौर से पढ़ेंगे. अब आप जो है अगर क्वेश्चंस ऐसे बनाते हैं जिसमें स्टूडेंट्स को क्लियर गाइडेंस नहीं मिलती, डेफिनेटली अगर एक स्टूडेंट 2 लिख रहा है, दूसरा 5 लिख रहा है, तीसरा 10 लिख रहा है, इसका मतलब ये है कि कोई क्लियर गाइडेंस नहीं है.
जी
So I,
सर।
so I think it's not fair. The question should be very very clear to the student, और स्टूडेंट को एग्जैक्टली पता होना चाहिए कि आप उनसे क्या चाह रहे हैं.
जी सर।
Any other question? आप लोग जो कह रहे हैं कि आप ब्लू प्रिंटिंग को फॉलो कर रहे हैं, तो आप इसी फार्मूले से कैलकुलेट करते हैं?
नहीं सर, हम
सर
स्ट्रिक्टली नहीं फॉलो कर रहे।
जी
नहीं
तो
सर,
टॉप
मैंने
सर
किसी
हम
स्ट्रिक्टली
इस
नहीं कर रहे।
फॉर्मूले उससे ने फॉलो करते हैं।
तो कैसे करते हैं आप ब्लू प्रिंटिंग?
सर हमारे वो मुख्तलिफ जैसे फील्ड है, वार्ड वर्क है, जैसे मैं लेफ्टिनेंट कर्नल शहनाज हूँ, मैं असिस्टेंट मेट्रन पोस्ट हूँ, और मैं वार्ड में जो मेरे पास स्टूडेंट आते हैं, मैंने उनको ब्रीफ समरी बनानी, ऐसे उनको गाइड करना, तो उसके मुताबिक हम उसको ना मैनेज करते हैं।
सही.
बेसिकली क्लिनिकल में आके, वार्ड्स में आके उनको सारे पेशेंट में से कुछ एक पेशेंट लेके असाइनमेंट दे दी जाती है कि आपने इसकी असेसमेंट करनी है, इसका ये करना है, और फिर हम उसको मार्किंग करते हैं।
राइट. तो इसमें चांसेस हैं कि आप वही चीज रिपीट कर लें, पर करें जो एक क्वेश्चन जो है वो थ्योरी में भी आ रहा है, वो प्रैक्टिकल में भी आ रहा है, वो क्लिनिकल में भी आ रहा है, ऐसा मुमकिन है?
तो कॉलेज से लेके आते हैं एक अपने वो ना टॉपिक लेके आते हैं, उसके
सही.
मुताबिक हमने उसको ना उन्हें गाइड करना होता है, उन्हें बताना होता है।
राइट. तो इसका मतलब ये है कि टॉपिक पहले से डिसाइड किए हुए हैं, उनमें से आप एक टॉपिक पकड़ती हैं और वो स्टूडेंट को उस पे.
सर मैं एज ए वार्ड में असिस्टेंट मेट्रन पोस्ट हूँ ना।
जी 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 जी. तो आप बेसिकली अगर आप थोड़ी सी कोशिश करें और इस फार्मूले को अप्लाई करने की कोशिश करें, क्योंकि इसमें मेजर चीज जो है
सर
वो
बहुत सारी
रेलेवेंस आ जाती है.
क्लियर हुए मेरे, बहुत सारी
इसमें जो है ना रेलेवेंस आ जाती है जब
और हम
चीजें मुझे
एग्जैक्टली
क्लियर हुई
हाँ
हैं,
जी, हम
इंशाल्लाह
अभी
हम इस
एग्जैक्ट जो है वो इसको हम अभी फॉलो नहीं कर रहे, टॉस्क और ब्लू प्रिंटिंग को।
जी जी.
जी।
लेकिन अगर हम जो है ये देखें कि उसका इम्पैक्ट क्या है और उसकी फ्रीक्वेंसी क्या है, और उसके
सर इसी तरह
हिसाब
फिर
से
फ्लॉज ज्यादा आ रहे हैं ना, स्टूडेंट्स भी डिससेटिस्फाइड हैं कि जो है ना वो आउट ऑफ कोर्स वाला वही एक उनका होता है कि ये आउट ऑफ सिलेबस है, आउट ऑफ कोर्स है।
सही. हाँ, नहीं
और
तो आई थिंक ब्लू प्रिंटिंग वुड सॉल्व मोस्ट ऑफ दीज प्रॉब्लम्स.
yes sir, this is the best way to solve the problem. Yes sir.
यस सर।
Right. Any other questions or comments? Well, thank you for your attention. Hope it was a useful session.
नो डाउट सर,
And
थैंक यू वेरी मच सर।
thank you.
Yes sir, it's very useful, लेकिन सर इसमें एक्सपर्टीज हमें जो है ना वो टाइम लगेगा, टाइम
हाँ,
टेकिंग।
नहीं मैडम, कोई ज्यादा मुश्किल नहीं है, थोड़ा सा अगर बैठ के इसको एक दफा करेंगे तो ये इंशाल्लाह क्लियर हो जाएगा.
यस सर इंशाल्लाह।
ओके.
सर अगर इसमें कोई और हमें बनाने में कोई प्रॉब्लम हुई तो हम आपसे कांटेक्ट कर सकते हैं।
श्योर, नो प्रॉब्लम, नो प्रॉब्लम.
थैंक यू।
अल्लाह हाफिज.
अल्लाह हाफिज।
अल्लाह हाफिज सर, थैंक यू सो मच।
अल्लाह हाफिज.